Well, thank you everyone for joining. This is Dr. Ashkan Lashkari. I'm MOASC president and really excited to introduce our moderator and panelists for tonight's discussion, which should be very interesting as it's focusing on the management of brain metastases in patients with melanoma, which I think fortunately we've seen some great breakthroughs over the last few years with both targeted and systemic therapies. So I'm going to introduce Dr. Greg Daniels, who is a medical oncologist focusing on skin cancers. And he's over at UCSD and is doing a great job and has been working with us at MOASC for several years now. And he'll be our moderator and we'll be going over the cases. He'll introduce the panelists and this is meant to be an interactive forum. So if you have questions, please place them in the chat box and then we'll get to them very quickly, and we should be able to open it up to some question and answer forum as we go through these cases. So, Dr. Daniels, I'll let you get started and introduce the panelists.
Great, thank you. And I'm going to start sharing my screen to do that. And hopefully everybody sees my screen and still hears me. So as Dr. Lashkari said, thank you, MOASC, for putting this on. And Dr. Parks put on a series of these through different issues with skin oncology, and we thought that these have value when we bring together people from some different perspectives about the problem, and certainly brain metastases fills that niche. So yes, my introductions are going to be Dr. Margolin, who has been everywhere, medical oncologist, deep in melanoma for years and years, and currently up in Santa Monica area at St. John's, and has led several studies and participated in studies for melanoma patients with brain metastases, among many others. Dr. Shawn Hervey-Jumper is a neurosurgeon from UCSF, been up there for 9 years. Prior to that, he was in Michigan. And Dr. Parag Sanghvi is a radiation oncologist here with us at UC San Diego. And Dr. Lashkari runs this show. So with that, I put out some learning objectives. So really tonight's informal. You are able to unmute and interrupt us, but you can also put in comments with questions. And then in general, we're just going to go through about 4 cases. And I'm going to go from relatively easy, if there's such a thing in brain metastases, to a little more complex. And what's changed in management has been our expectations that patients with brain metastases can do well, and our task is to get them to that point where they have the opportunity to do well. So making some early decisions about that. And so hopefully with the cases, we'll kind of get to some of those things. And if they bring up questions, again, please either raise your hand or speak up. So we'll start off. Not an unusual thing where somebody has a remote history of a melanoma, appropriately goes through life with routine dermatology, thinking nothing of it, but maybe has a little bit of warning that they had melanoma. But then had CNS symptoms with dizziness and headaches, went to the ED, and imaging showed a lesion. And there I popped in the solitary brain metastasis up top, as well as lung lesions were discovered. So history of melanoma, 7, 8 years before. Some of the things to think about, do we need a biopsy? Best primary management for a patient like this coming in symptomatic, again with some CNS symptoms, and then what's the role for surgery radiation? I'm going to pause here and let kind of our discussants jump in, and then we have some notes on the next page. So maybe Dr. Margolin, have you lead us off?
Sure, thank you. This is not an unrealistic case at all. As many of you probably know, most of the deaths from melanoma actually come from patients who started with very low risk early stage disease, because there are so many more of those patients. And so even a low frequency event times a lot of people will lead to that being the majority. Nonetheless, it's been 7 or so years since his original diagnosis, and it was low risk. And this is an area, the lung and the brain, where other things can also occur, particularly lung cancer, even though these lesions look quite metastatic in nature. So I would certainly vote for a biopsy. Whether it comes from the lungs or the brain is going to depend on whether you need tissue from one particular site over the other, or whether there's an indication for surgery in one or the other site. So I'll stop there and can move to somebody else.
Well, I might call in Shawn, because this person probably got an ED neurosurge consult when they hit there. And so what are your initial thoughts on seeing go back to that,
Yeah.
not going back to that MRI.
So our standard guidelines for a solitary brain metastasis, certainly over 2 centimeters in size, is resection. I will say this lesion itself does not have a lot of perilesional vasogenic edema. So if you ever were going to get away with a biopsy and radiate, this would be the one. From a neurosurgical standpoint, cerebellar lesions worry us. It's not a big cavity. And so a small amount of swelling can make people pretty sick pretty fast. So we do have a slightly kind of lower index for removing cerebellar brain metastasis. So again, seeing this patient in the ER, I would actually, if they had pretty evidence of decent amount of systemic disease control and a prognosis we estimate to be greater than 6 months-ish, I would probably offer the patient resection if we thought they could benefit, they could have the 2 weeks or so, 2 or 3 weeks to recover from a craniotomy. If our colleagues thought they needed to be on systemic therapy treated faster, then we obviously would defer biopsy the lung and radiate only.
Great. And I'm going to hold off on you for a second, Dr. Sanghvi, because what's going on? She does get, resection and get some adjuvant radiation afterwards. And so maybe you can comment on the use of radiation in a scenario like this.
Yeah, no, I am, this is a delayed recurrence single brain metastasis. I agree with everything that Shawn said. This would be a patient that I would be calling Shawn and advocating for surgery, even though there's not a lot of edema. Just to really, this is a tight area. I think debulking makes sense. I think in terms of radiation, there are multiple options now. You can do preoperative SRS, you can do postoperative SRS, but definitely would need, in conjunction with surgery, they would be buying in some radiation, either preoperatively or postoperatively.
Now, off the brain lesion, you get your NGS, and pose a question: would you want to know biopsy of the lungs, or is a PET enough for you to go on? And if so, what would be your next move, Dr. Margolin?
This patient now has been rendered sort of free of disease in the brain, still has a couple of lung metastases, which I would probably not favor operating on right away. It's blood-borne disease, it's to multiple sites. And I don't think you need a biopsy to prove the diagnosis now that you have brain metastasis with tissue. Because we've learned that for BRAF mutant melanomas, you can treat systemic disease with oral MAP kinase inhibitors, but even in the presence of a BRAF mutation, patients in general with metastatic disease do a little bit better if you start with immunotherapy and only give MAP kinase inhibitors if the patient fails immunotherapy, or if the immunotherapy fails to cure the patient. I would use a fairly aggressive regimen of doublet of immunotherapy. The benefit is that it has the highest overall response rate and survival in comparison with anything else that's available, and that drugs that are used to aggressively treat metastatic extracranial disease work pretty well for intracranial disease, so that presumably by extrapolation, the use of such therapy would lower the risk of new brain metastases, which the patient is certainly still at very high risk for.
Okay, well, you mentioned doublet, and in your red discussion notes when you were thinking about this, you talked about some alternatives to that doublet, Ipi-Nivo or Nivo-Ipi or Opdualag, or do you have a preference? And
You want me to continue with that, or shall we turn it over? Okay.
yeah.
Yeah, I mean, the study that I led together with Hussein Taubi in around 100 patients showed very promising results in patients with asymptomatic, non-steroid dependent brain metastases that had essentially a very concordant response rate and, relapse-free in that compartment, survival between brain and extracranial disease. It was a single arm phase 2 type of study, so there's no way that one can claim that's better than at full doses, that it's better than using flip doses, or that which is associated with somewhat less severe adverse event spectrum, or against Opdualag, or any other combination. I think most people feel comfortable, based in part on randomized data from Australia and others, as well as single-arm data, that single-agent PD-1 blockade in melanoma metastatic to the brain probably does not have the power of that doublet. But I would like to point out that, more and more these days, patients who have had their disease in the brain sterilized with surgery and SRT, or with just SRT if small and asymptomatic, are, after a reasonable interval that's protocol defined, generally still eligible for clinical trials, even if the clinical trial is not directed at patients with brain metastases specifically. So I would not rule out the possibility of finding a good trial for this patient.
Great. Yep. And, part of our thinking, and hopefully, thinking about the neurosurgical aspect of this, as Dr. Margolin said, we're trying to think about patients, getting them to a quote unquote asymptomatic, non-steroid dependent fashion. And so sometimes when I'm calling neurosurgery, that's the concept I'm trying to get across. I understand that they have metastatic disease, but we're trying to set them up for the long run. This patient ended up getting Ipi-Nivo, Ipi-3-Nivo-1, and did well. Had a few things go wrong, but that's typical. I'm going to move on to the next case, because I think, as I said, we start off with success and then we keep moving. So this is another early stage, as Dr. Margolin points out. It's not an uncommon scenario. Patient who had, again, neurologic symptoms as the initial complaint, driving their car on the freeway, had some sort of weird thing, pulled over and crawled under his car, and woke up in the emergency room. With imaging, as you see there, the MRI not only found that larger lesion in the right parietal, but several other small, definitely sub-centimeter lesions. And then his CT scan showed stuff. So again, now we got multiple brain lesions, symptomatic patient with distant disease. Any hesitation there, Dr. Hervey?
No, I'm particularly keen in getting this patient symptom control too. As you can imagine, the right side parietal motor cortex is pretty obliterated by the vasogenic edema, so they should be pretty weak on the left side. And so the goal here is to remove that right parietal lesion, get them off steroids, but also give them better motor control, especially leg, right? I talk to patients a lot. It's easier to get your way through complicated oncology care if you can walk through it, right? So the goal would be to maintain mobility here is with surgery and get them off steroids, as you mentioned.
Great. Dr. Sanghvi, you can irradiate 20 lesions at a time with stereotactic tools these days. Would you be tempted here?
No, I mean, I think that I agree. I think, location, location, location. And so this is definitely a location where I think that, surgery is going to give, much more immediate symptom relief than any radiotherapy. So I would advocate for definitely surgically resecting this dominant mass to get the patient feeling better.
Well, and that's what they did, resected his right parietal lobe lesion, and left on steroids, as well as some Keppra. Ended up having a follow-up scan, which shows you the post-op changes here, although it looks a little bit in a different spot now that I'm looking at the scan. And then a couple other lesions that had increased in size. So going out on steroids, what shall we do? What do we generally do post-op for a patient like this? Anybody?
Yeah, I was going to say, certainly, I think irradiating the resection bed of that resected lesion makes sense. As Dr. Daniel said, there was a time where I would radiate every melanoma brain metastasis, and I think that era has changed. So, in a systemic therapy naive patient, really would look at the geographic distribution and size and any related edema for the rest of the intact brain metastases. And then I think it's really a nuanced call to see what warrants upfront radiosurgery versus where, if you're immunotherapy naive, could I let Dr. Margolin or Dr. Daniel start with some dual checkpoint inhibitors and look at that intracranial response before coming in with radiosurgery.
Yeah, and I'll just point out that our NGS helpful panel has pointed out everything that I would not give this patient, which is single agent immune therapy or BRAF inhibitors, as long as they're feeling well otherwise, and we think we can get them off steroids and onto the dual checkpoint therapy. And luckily, that's kind of how it went for them. They were able to get off steroids, did not have any more seizures, ended up having some ipi-nivo. But shortly into it, got their follow-up brain scan, and they had some more swelling, another new lesion, continuing on, started getting nauseated, loose stools. So things are getting a little bit dicey. Thoughts on the new lesion? How are you going to handle these mild to moderate symptoms coming up on both checkpoints and swelling? Dr. Margolin.
Well, we like to say that a little bit of growth is something to very specifically not get panicked about, and to consider one of two possibilities that are a little bit hand-waving in nature, but until we have a better explanation, I think we accept it. One being that, you know, immune responses take some time to develop, and that the appearance of regression, even in the presence of a good immune response to systemic therapy, may take a few weeks to occur. And we certainly know that more in extracranial disease, but we have occasional examples of that sort of pseudo-progression phenomenon before a response. The other that's even, I would say, more hand-wavy, but of course it's not at all practical to study this concept, is that there are lesions that appear to increase in size because they become infiltrated by immune cells and other you know, accessory cells of an immune tumor microenvironment of an effective nature, you know, myeloid cells and fibroblasts and so on and so forth, and maybe even some fluid that comes as a result of local inflammation. So in the absence of, you know, really pressing new symptoms, we do try to wait and continue therapy. And in the presence of more pressing symptoms, although reluctantly, we may give steroid, or we may try to temporize with some bevacizumab, which I think we talk about in subsequent cases, as a way to give a kind of steroid-sparing, edema mitigating type of therapy.
How would you feel about giving this patient bevacizumab at this point, since he's nauseated, maybe having some brain edema issues after a couple doses of ipi/nivo, but he has, let's say, mild hemorrhaging around a couple of the lesions? Any hesitation?
I think I would lean towards steroid in view of the other things that are happening. A little bit of headache, a little bit of colitis. I've never seen anybody switch from ipi/3/nivo 1 to ipi/1/nivo 3, but it's a thought.
Yeah, totally not supported by data. So this is just a practice discussion, not necessarily a data discussion. But yeah, he was switched to ipi/1/nivo 3 just to lower down the colitis issue, and it seemed to work. And he ended up doing fine. Okay, however, let's again go to the next notch on our volume list. So 60-year-old now with multiply recurrent melanomas and a little bit more complicated relationship with checkpoints. So this was a head and neck melanoma that was resected, had some adjuvant therapy for node-positive disease, but it led to an inflammatory arthritis that he was ultimately put on methotrexate for. A couple years later, still having to take immune suppression for his checkpoint-induced stuff. He had another recurrence. It was just excised. Sentinel node was negative. This was an in-transit recurrence. No more adjuvant therapy was given. And another recurrence happened down the neck, which was resected. And at this point, stopped his methotrexate and gave ipi. Who knows if that was right, but you know, his symptoms came up on PD-1 and felt like we needed to do something. He got the aches and pains that were back either from stopping the methotrexate or from the ipi. But he kind of suffered through it for another 3 years until he had another recurrence. At that point, that was resected and he got radiation. So, unfortunately, he developed systemic disease. And so CNS was negative at this point, got ipi/nivo and responded, ultimately getting a complete response. So here's a gentleman who's never had brain metastases and just curious, had a nice response to ipi/nivo, although immune kind of suppressed, weird a little bit. How often would you do brain imaging? Does having hydroxychloroquine or maybe even prednisone in the background make you nervous? How do you look at this? And again, sorry, I'm picking on Dr. Margolin, then we'll get to the others.
Okay. Well, as far as the routine brain imaging, in the case of somebody who had negative brain imaging at the time of staging and the finding of metastatic disease outside the brain, I would probably do it after 6 months or so, maybe at a year, and every year if he goes into remission. Obviously, you do it PRN any symptoms and any relapse. It's more just a matter of common sense in a data-free environment. I've certainly never had an insurance company, of all the things that they've denied, I've certainly never had them deny a brain MRI in a patient with melanoma that I can recall. And yeah, I would say that the response to therapy would influence the frequency of imaging, just as I've said. As for the use of immunosuppression with methotrexate or hydroxychloroquine that are both directed at a rheumatoid-like phenomenon, it seems like that was a pretty life-altering syndrome that he had. And I don't think either of those drugs is highly immunosuppressive, and therefore I think that compromise is very reasonable, and have done exactly the same with a patient who's almost identical to that in my own clinic.
Great. These are the answers. So then, of course, he develops a brain lesion, which was picked up on a routine CT head. No headaches, exercising. That was one of his ways to deal with the aches. And MRI just showed a solitary lesion. Given steroids by his outside doc. So just kind of thoughts on this case. Steroid use, role for surgical confirmation of the brain lesion, and just remind you what it looked like here on this. I'm not giving you a lot of images there, Shawn, sorry. They described it as this bilobed lesion.
Yeah. When it's hard to, take someone to surgery for such a small lesion. It sounds like they were not symptomatic, right? I was looking back through the slides, not terribly symptomatic from this.
No.
Yeah. So I would just certainly want to know what my radiation oncology colleagues talked about. I would quote them the rates, from a neurosurgical understanding of disease control with and without radiation. One caveat I would put on the table, we didn't discuss this to any great length, but laser interstitial therapy is a kind of a moderate approach we could use if we, worried about disease control with radiation alone, and or we wanted tissue confirmation of what this is for any particular reason, which I don't think we really would need, but that's another treatment option I would put on the table. But I would not jump for open surgery unless we had a compelling reason for this patient at this time.
I'd love for you to comment on that when we get to more radiation necrosis and your thoughts on it there.
Absolutely.
Okay, so
May I ask a question? The laser interstitial therapy, is that fully ablative, or do you follow that with SRT?
Fully ablative. It depends upon the volume. And I'm staring at a radiation oncologist as I'm saying this, but your max ablation zone is about 2 centimeters tops for anything other than radiation necrosis. So you can have scenarios where you've created a kind of a hot dog shaped hole in the middle of a larger lesion if you don't choose the lesion correctly. But it should not need to be followed with SRT if you choose the correctly, like geometric shape of the lesion in the right patient.
Okay, Dr. Sanghvi, how would you approach this?
Yeah, I would say, I guess if surgery is not on the table, this gentleman's had multiple, issues with IO. So I do think that this is a good candidate for primary SRS if we're going to avoid surgery. So I would offer that. I think in terms of steroids, I have a love-hate relationship with steroids, as does every CNS-directed person. So, if they're asymptomatic, honestly, I would dial down the outside steroids very quickly and get them off steroids. And just treat this patient with stereotactic radiosurgery.
Perfect. And so that's what happened. Got some SRS, got off steroids quickly. He actually, I don't even think he took the steroids because he took one dose and it made him feel weird. And so here's the progression from left to right, sorry, of this lesion on the MRI. So a month after primary therapy, and then a couple months later. And now I think he was starting to get some symptoms. And what he was talking about was some visual kind of functional things. His outside radiation doc gave him some steroids, which again he had stopped, and was having word finding issues. So kind of maybe we'll start with you, Parag.
Yeah, certainly. I mean, I think imaging findings are concerning for just radiation response. So things that I would think of doing is adding perfusion sequences to an MRI. Perhaps, if the neuroradiologist think that this is a good location for a single voxel MR spectroscopy, that's on the horizon, and a dedicated brain PET. And I think oftentimes you find that you need a combination of all of these three to improve the sensitivity to confirm that this is radionecrosis. But I would start that for a diagnostic workup.
Okay. Any other comments? So didn't like the steroids, symptomatic. Are we ready for bevacizumab, and how do we use it?
Can I ask a question? I'm sorry, this is
Yeah,
Ashkan
please.
Lashkari. Hi. So one thing that I think a lot of us who treat melanoma have discovered, and especially those with brain metastases who then, live long lives because their disease is well controlled and they go into prolonged remissions, is that if they have received prior radiation, they're often at high risk of developing radiation necrosis down the road. In other words, my experience has been that have had quite a few patients with melanoma and brain metastases who've received radiation, ultimately developed radiation necrosis. And it's a bit of a scourge in my clinic because it's, as Dr. Sanghvi mentioned, it's very difficult to figure out whether this is, a recurrence versus radiation necrosis. It can happen, at variable timelines, especially if it's, quite a bit after the diagnosis. Sometimes, you're worried that it could be a new lesion, but so I'm just curious how people, in their own practice kind of deal with this because, I certainly get a lot of these MRIs with, mass spectroscopy and spectrometry, and I haven't done PET MRI. I mean PET brain imaging. I wasn't sure that was something that could even be done or is available in the clinic now.
Yeah, I would say, I mean, these are diagnostic challenges, and I think looking at the timing of symptoms, and timing of these radiographic appearances is somewhat helpful. So I'll typically say that if you're looking at a 6-month to say a 2-3 year time period, that it is more likely to be radiation necrosis than progression. I have to remind everybody, when we do intracranial radiosurgery, the doses that we're giving are limited by the biologic tolerance of the brain. So these doses are really meant for kind of local control on the order of 1 to 3 years. If the same lesion were in the lung, I'd be giving 3 times the dose of radiation when I'm doing ablative radiotherapy for a lung metastasis. So as we all now have these melanoma patients living, 3, 5, 7, 10 years, with progressive time, I think this is where it truly becomes a diagnostic conundrum. It's oftentimes you'll see there's, the perfusion images are mixed. The spectroscopy is not terribly helpful. PET sometimes is not terribly helpful. So I think then really I call Dr. Daniels and kind of go from the least conservative treatment option to the most aggressive treatment option. So starting with, steroids, if steroids are tolerated. If steroids are not tolerated or symptoms return, then going to bevacizumab. And then after that, if you still have symptoms, then going to surgical resection, especially years out. I mean, we've seen some of our patients develop these very large vacuolated lesions that are just these large cavities that are progressing, almost like a cystic lesion where we really need surgical evacuation plus minus lit. So I do think that as our patients are living longer, we're certainly seeing the natural history of treated brain metastases play out. And I agree with you that these can be a significant long-term, it definitely keeps the work interesting, but it can be a significant long-term issue for some patients.
Yeah, I'll comment on this as well. I feel like this is coming up at an increasing rate in terms of neurosurgical consults. For me, the indication for surgical resection versus laser interstitial thermal therapy is following the volume under 3 centimeters. As you can imagine, a ball of necrosis pretty much melts away when you burn it. So you can ablate a larger volume. Second factor is the speed at which you need or want to get a patient off corticosteroids. Laser interstitial therapy is whopping doses of dexamethasone for the first couple of weeks or first couple of days, and usually you can get it down or off over 2 to 3 weeks. Many times these patients have been on dexamethasone for months by this point, so it's not always that easy. And the third is proximity to things you care about. Our current technologies don't do a good job of not burning things that you want to keep intact. So you notice on this scan, the image before, I believe, on the medial side of this, you're getting relatively close to the cortical spinal tract. And so you would definitely, want to, you can put a voxel and tag and make sure your ablation doesn't actually get above a certain temperature at a region of interest, but it's still not perfect. It's not very good at preserving like subcortical structures. So in patients like this, oftentimes, when you're thinking about function preservation, I'll just make a small craniotomy, open and resect it rather than ablate it, just because, again, motor control is a particular concern. Hope that.
Yeah, I'll just make one comment. I think the only thing that's really helped me is finally accepting that I might not know, and I just have to do something. And sometimes that, as Dr. Sanghvi said, I might escalate it from least to most aggressive. But in that consideration, I always hesitate. I don't want to put a patient in a bad spot where I've given them bevacizumab and then they're going to surgery. And I don't know from a surgical side if that's much of a concern. My neurosurgeons lately have not been too concerned about that, but I don't know how you feel. If I gave him, bevacizumab and now all of a sudden he keeps going and gets worse.
Yeah, no, it's bevacizumab is not our friend. As you can imagine, you need new blood vessels to heal an incision, and I can remember the kind of horrendous cases of rushing somebody to surgery after bev, and the incision just falls apart despite your best efforts. Our literature suggests at least 4 to 5 weeks between doses. Times in which we will operate prior to that and keep the sutures in longer periods of time. But I personally would never mind being part of the conversation up front if you're deciding between the two, rather than learning later that they just got a dose of bev and then you worry about infections and things like that. I tell the patient, if we do our job right, then you just heal up, and 2 or 3 weeks later you're back on, back working through systemic treatment. But if you have an infection because of a lingering incision problem, you're really talking about minimum 6+ weeks, maybe longer of antibiotics and no systemic therapy or minimal systemic therapy because of that. So I don't think many neurosurgeons would be upset being part of that conversation early, so we can balance these risks and benefits up front.
Yeah, I agree. Great point. Okay. Well, they did get bevacizumab. I'm sure I talked to the surgeon. And he actually symptomatically got better pretty quickly. You can see the evolution again from left to right with the with the BEV. You know, he checked his blood pressure at home, again, seemed to do okay. I'm not sure we need to talk much more about this. You know, I find sometimes that the radiation that it does it again, maybe 6 months later, maybe 18 months later, and then I'm also scratching my head, like Dr. Sanghvi said, is this a delayed recurrence now? Am I being fooled? I got lucky before, you know, with my assumption. So these are all normal, I think, and correct questions to have at this point. So moving right along to solve this one, 78-year-old gal. She had a scalp lesion. I didn't know. The records were a little bit incomplete, but I'm sure it was a stage 1. And then 5 years later, came presented with some language issues, found at the emergency room on CT scan to have lung lesions and brain lesions. And I pop up an early representative slice of the brain with a larger enhancing lesion with associated edema, and at least 6 millimeters in my measurement of shift. And you can see in the background a few smatterings of lesions. So this patient's symptomatic with multiple brain lesions. Now, I didn't show you all the slices, but I put a different one up there just to show you that there's something in the brainstem if you didn't speak out to you. And probably if you added them all up in this relatively poor quality MRI, there was at least 30. So what do we want to do?
Can I say off the bat, you know, this scenario is so nuanced that even our neurosurgical guidelines, our American Board of Neurologic Surgeons, Congress of Neurologic Surgeons, tumor section guidelines are really out of date compared to what we do. Standard treatment in this day and age for neurosurgery is actually to remove the dominant lesion with the goal of symptom control and getting the patient and a minimal or zero dose of dexamethasone, right? Especially in a treatment-naive patient. Again, not reflected in our current guidelines and why they're actively being rewritten to address these sort of gaps.
Great. Dr. Sanghvi?
Yeah, so I'll start with, you know, is there a role for whole brain radiotherapy? You know, I will say whole brain radiotherapy unfortunately does not work in melanoma. So I loathe thinking about whole brain radiotherapy. And as Dr. Hervey-Jumper mentioned, I think even with 30 lesions with a dominant, that right parietal lobe lesion with significant edema and a midline shift, I would consider resection of that dominant lesion. And then really look at the geographic location of lesions. You know, I would irradiate the resection bed, and I'd probably irradiate this brainstem lesion for sure. But the rest, again, you know, in a patient with small, you know, relatively asymptomatic lesions who's naive to IO, my job is to get them as fast to IO as possible. And so that's what I would consider.
Would the genomics change your approach if this was a BRAF mutated patient, Dr. Margolin?
Well, the first thing is that this particular patient doesn't have a targetable BRAF mutation. These are all variants that are, I mean, the closest is this protein T599 to I. And, you know, as a general rule, we sort of think of anything that's nearby 600, maybe possibly associated with a response to targeted therapy that with this concept that it may be activating, you know, the BRAF pathway. And I guess the variant allele fraction would suggest that, but I wouldn't be very excited about this being considered a BRAF mutated melanoma, particularly for purposes of treating disease in the brain, because although MAP kinase drugs are felt not to get into the brain well, in the presence of metastatic disease, they seem to get in well enough to give you responses at a reasonably high level, but not as high as they do for metastatic extracranial disease, and the responses don't tend to last as long. I was just describing to a patient today in clinic that, again, some of the hand-waving-ish ideas for why that should be the case. I think the two biggest contenders are that when a metastasis is growing in the brain, it has developed some clonal evolution and there are new mutations, or B, and this is of course with V600E or V600K, and the other would be that the relative leakiness of the blood-brain barrier, and sorry, Shawn, if I'm, saying things that sound really sort of, like kindergarten, but let's say we accept that, that the permeability of the blood-brain barrier to drugs that ordinarily don't get in is possibly restored by the regression of the lesions initially, and then you no longer could get drug getting into the brain, continuing to act against the lesions. So that's where I would rely on looking, glancing at those genomic studies and say, no, I don't think so.
Yeah, great. So they did get resection, and I actually had initially met them 3 days into their whole brain radiation.
Yeah.
We had to kind of redo the plan, but got radiation. What we did was focused on the brainstem and some of the larger lesions, and gave some ipi-nivo. Unfortunately, we got into some toxicities, both lung toxicities and colitis. And despite trying to nurse them through, got progression in the lung and brain. So at this point, any other options you can come up with? I know you said, Dr. Sanghvi, you wouldn't give whole brain, but
yeah, I would just again keep cherry picking new lesions with radiosurgery, as long as the performance status allows. Yeah, I would keep holding off whole brain.
well, it's a case in progress. So
Sorry, can I interrupt for a second?
yeah.
What about the concept of using Nivo alone if it's not progressing? Did we see we saw pneumonitis, and that's the reason not to give. Okay.
Yeah. So open discussion, if we haven't covered it already and everybody has the ability to unmic or raise their hands or put something in the chat. We have a few more minutes left with I think a pretty world's expert panel, something like this. So open it up for questions.
If we don't have enough, I would definitely like to present a patient I saw in clinic today. So we'll just keep that in our pockets. That'll be our quiver slide.
I guess I have a question for the panel. Would be PD refractory disease. So they've been on adjuvant treatment and they present with a brain met or multiple brain mets. And how do you approach that patient? Maybe Kim.
Well, in the absence of first of all, this might be a place where if the tumor is known to have a BRAF V600 mutation, you could justify using MAP kinase drugs. I don't think it matters which of the three available doublets you use, vemurafenib and cobimetinib, dabrafenib and trametinib, or encorafenib and binimetinib. They've all been shown to have activity in the brain. I think in the highest valuable studies, it's safe to say that they don't work quite as well in the brain or for quite as long, but they're nothing either. So that's one option. And the other option, either in the absence of a BRAF mutation, or if you want to gamble on that approach, would be to double up on the immunotherapy, again with CTLA-4 plus PD-1 blockade, which in extracranial disease, in the absence of brain metastases, and in patients who are known to be PD-1 antibody refractory, a good size randomized phase 2 in SWOG that was recently published showed that a double immune checkpoint blockade, despite the PD-1 refractoriness, had an overall response rate around 30%. Whether you can expect that, and CTLA-4 block alone was about half that or less. Whether you can expect to see that in the brain or not, probably depends on a whole lot of things. But it's another option. So of course, the idea of radiating anything you can radiate is another choice.
Okay. Well, I don't see questions in the comments unless I'm missing them. So what's your case?
So I have a young lady who's around 45 who had a very early lesion in the area near her ear a couple of years ago. And so that was removed. And I think that was node negative, and it was probably a 2A or something. So she didn't get any adjuvant therapy at that time. She came back, let's say last year sometime, maybe a little before that, early last year, with lung metastases. Originally, they were clustered in one area and they hadn't been tissue documented. So she had those resected, a couple of small nodules in the right base. And unfortunately, as she was undergoing a workup for a randomized adjuvant trial of one thing versus another for metastasectomy, NED, she developed a new lung metastases. So she went on Opdualag as her first systemic immunotherapy. She, and I did mention she had a BRAF V600E mutant melanoma. She actually got only 3 Opdualag cycles at the standard 1-month interval when she had progression in the lungs and the liver. Each time she changed therapies and had a relapse, she did have the brain imaged, and at each of those times, the brain was negative for metastatic disease. She, because she progressed on Opdualag and had a V600E mutation, I went ahead and switched her to encorafenib and binimetinib. She's tolerated it extremely well, and she's had a very, very good response of all her disease, which by then had been fairly high volume asymptomatic disease in the liver and the lungs, low volume disease in the lungs. And she continues to have an active life with a couple of teenage kids and a job in a school. The last time we restaged her, routinely, it had been several months, she was found to have asymptomatic, approximately 3 or 4 small brain metastases without edema. She did not require steroid, and nothing that would beg for surgery. So she's been restaged, and all of her extracranial disease continues to be absent radiographically, and she's getting ready for SRT to what'll turn out to be 4 or 5 lesions, let's say. So, I would love to know what my colleagues would recommend at this point. And I'm open to suggestions, although I sort of know what I want to do, but I'm not going to tell you yet. So everybody's smiling,
how long has she been on,
except for Dr. Hervey.
Yeah, how long has she been on BRAF?
Oh, she's been on for about 16 months or so. So she's longer than the average.
Yeah. And so I'll tell you what I would do. So I would probably irradiate, but I would definitely put her on ipi-nivo. And even if I do irradiate, I'd still put her on ipi-nivo. And then I'd just write it out. Yeah.
Do either of my colleagues from non-medical oncology specialties want to jump in this pond?
Yeah, I guess my decision to radiate or not radiate would depend on what do you have next in mind for this patient, certainly. And you know, I think that I perhaps maybe in the minority for radiation oncologists, but I will say that, you know, kind of just seeing the natural history of melanoma, I am very nuanced in what lesions I irradiate. You really need to put that in the context of the life expectancy of patients and what the other systemic therapy options are. I personally am in big favor of using immunotherapy because I think, as everybody here can agree, that it changes the velocity of intracranial progression. And I want to ride that out as much as possible because I always tell patients there will be a day where you will need me. And I'm very cognizant of A, what local control is with intracranial radiosurgery and how long that lasts, and two, what the long-term complications of radiosurgery are, especially as patients are now living 3+ years out with brain metastases. So I would take all that into consideration and then decide. I'd probably, I mean, you know, larger lesions, anything that's, you know, radiographically in a anatomically sensitive location that may cause functional deficits. I'm all about radiating those lesions and taking the risks and taking those chances. But small, particularly small, I would say sub-centimeter, particularly sub-5 mm lesions. Honestly, I don't know that radiation upfront as frontline therapy is the answer for these patients. You know, I'd hold off until I really need to come in.
Dr. Hervey-Jumper, do you want to jump in, or are you content with that discussion so far?
No, I'm quite content, actually. I think, especially Parag's comments, I don't have anything else to add to that. I think it was really, really well put.
Well, I'll tell you what I decided to do, although I'm, as I said, I'm still kind of open, but I think I'll probably go with so what I decided is that this young lady is, for sure, she's going to, you know, progress at some point extracranially. And I thought it would be nice if we could make her, you know, NED for a while. I wasn't thinking quite as nuanced as Dr. Sanghvi's elegant discussion about the, you know, the radiation selection. But what I thought I would do would be to radiate the 3 or 4 lesions she has and to keep her on the MAP kinase drugs for now with very close surveillance. And at the first next progression, wherever it is, switch her back to immunotherapy using CTLA-4 and PD-1 blockade. I guess that's due in part to my relative skepticism about the activity of immunotherapy following a long course of MAP kinase inhibitors. And granted, it'll only be longer if we keep her on it, but I'm not sure that the difference between, you know, 18 or 20 months and 16 months is enough to make her, you know, more sensitive now to immunotherapy than she'll be in a few more months. And you know, the best we do with the other thing is I don't know anything about the track record for Ipi and Nivo following Opdualag. I don't know if you do, Greg, but haven't seen much, if any, data. It's probably anecdotal. So I thought I would be a little more conservative. And then, of course, there's always the issue of what happens when you stop MAP kinase inhibitors. Early on when we had these drugs, we had all these stories of patients who would have these explosive relapses and they get very sick. And then, you know, immunotherapy doesn't work very well or very fast. And what do you do then? And I think that, you know, we came to realize that that might be due in part to the fact that many of the patients who were getting MAP kinase inhibitors first were very, very sick. And we saw these dramatic responses, but once they stopped responding, chances are that they're going to be very sick again. So I think I've taken one patient and introduced immuno while they were still on MAP kinase inhibitors for a week or two, just to be sure that they didn't explode. Not that that would prevent it necessarily, but just trying to be clever without any data.
Yeah, I mean, there is a little bit, and it's very little data of Ipi-Nivo after Opdualag. And it was maybe a year ago in New England Journal as an editorial. And then Michael Postow just put out his series of PD-1 refractory with brain mets and ipi-nivo, and I forget his numbers exactly, but it wasn't surprising. It was somewhere in the 20% kind of response rate after
Oh,
PD.
okay, I haven't seen that. Okay.
I think it came out a month ago or so.
Hmm.
But okay, well, oh, Dr. Shu has a question, and then we'll wrap it up. What adjuvant treatment would you provide to a patient with single resected brain lesion followed by adjuvant RT? At least 2 patients presented this way to clinic, no other systemic disease. Would you consider single agent IO pembro instead of ipi-nivo for a treated stage 4 brain only disease?
I guess that's gonna have to fall to me again, or maybe you, Greg.
You do it. Okay, we'll both go. I'd give ipi-nivo. I'd just give 4 doses and I'd call it a day. Yeah, I don't know what you do, Kim.
I have that patient in my clinic. I just wrote the orders today, and that's what I wrote for. I think it was not an unknown primary, but it was a distant primary, early stage, and then came back in with a very symptomatic brain metastasis that's been resected, and he's doing and then radiated, and yeah, it's there's going to be trouble. Although I have to say, before these drugs, I had the occasional long-term person who was free of disease, and you could wind up with no pituitary gland and type 1 diabetes, and then think, oh my God, I'm never going to do that again, which is anecdotal practice, but you do it, feels right.
Well, I'd like to thank everybody. Again, MOASC, Dr. Park, Dr. Lashkari, thank you for having us, and our panelists for answering my questions. Hopefully they answered some of yours. So,
Yeah, thank you so much for everyone. Wonderful discussion.
yeah. Okay, see you guys on YouTube.
Nice to meet all you guys.
Yes.
Thank you. Good
likewise.
night.
Good night.
Thanks for having me. Bye-bye.
Bye-bye. Thank you.